Let's Talk About Kidneys takes a deep dive into the chronic kidney disease patient journey. We're here to inspire meaningful conversations and to help people living with CKD gain a full understanding of their disease. Have you ever wondered how a primary care physician and a nephrologist work together to help manage kidney disease? On today's episode, we'll talk about the role of each doctor and how they partner together to coordinate a patient's care. Dr. Fuqua, I am so glad that we're going to get to sit down together today and really walk through the journey of what it would be like to be a new patient with Dallas Nephrology Associates, and also what that relationship looks like as you continue the relationship between the DNA care team as well as the primary care physician. So how can a patient really be prepared for that first visit with a kidney doctor or a nephrologist?
Okay, good question, Bree, and thanks for having me. So I would say always writing down questions is a good move for a patient, and that's across the board. A lot of times patients are wondering why they've been referred to the kidney doctor, and that's a fair place to start. And so usually the first 5 or 10 minutes of the appointment, we're just reviewing lab work and answering the question of how did you come to be here?
Mm-hmm.
And one of the challenges in our field is there's not a lot of symptoms discussion, and a lot of it revolves around lab work. And so we usually start the first few minutes breaking down that lab work and just establishing why they're here and what kidney disease is.
Yeah, what this means. Here's what your labs are. Here's what this actually means.
Mm-hmm.
Well, and I feel like I should probably have backed up. What exactly does a nephrologist, what is a nephrologist?
Okay. A nephrologist is a medical specialist, not a surgical doctor, and we manage people with low kidney function, which could be chronic kidney disease, which is a long-term problem, or acute kidney injury in the hospital. And we also manage patients with difficult blood pressure and electrolytes. But I think today we're going to be talking about chronic kidney disease, or CKD, and what that means is a long-term reduction in the filtration of your blood by your kidneys.
And so knowing that, I mean, what actually happens? We talked about the first visit and how they can prepare, right? And a big piece of that, like you mentioned, asking questions. I can imagine a lot of that is, I don't know what I don't know. So I'm sure they've come equipped with Google recommended questions. So what actually is happening? What types of exams and tests have been performed up until that point?
Most commonly, a patient comes to us when the PCP sees an elevation in the creatinine. And what I always explain is creatinine isn't that important in and of itself, but it's a handy marker for us to see how well the kidneys are filtering the blood. And if that number is elevated, that means that we may have a problem. And then what I'm seeking to do as a kidney doctor is identify what could be reducing your kidney function and fix everything that's fixable, and manage that reduced kidney function and hopefully stabilize it and keep it from turning into a serious or progressive problem.
And so do you really feel like you have to walk them through, in a step-by-step manner of here's what each of these labs, again, this is the first time they're hearing probably some of these words and terminology.
Right. Yeah. We walk through logically, starting with the serum creatinine. There may be other labs that they come with, urinalysis, estimation of albumin in the urine or protein in the urine. They may have a kidney sonogram. And even if they don't have those things, it's still a good jumping off point, and I'm going to order those tests to fill in the gaps and paint a picture of what's going on with their kidney health.
I can imagine from working with a primary care physician, some people have never seen a specialist before. Do they have some of those questions initially? Like, what does this mean? I've only worked with my general practitioner.
Absolutely. A lot of people are really anxious when they show up in our office, and the first question they say is, does this mean I'm going to need dialysis? And so a lot of times I take that one head on, and the vast majority of the time I can say, no, this is very unlikely to lead to dialysis or transplant, or I think that's a low risk sort of scenario, and here's what we need to do to figure out what's going on. But I like to try to take that head on because I can see a lot of anxiety in the first 5 minutes.
Right. And then it ends up clouding the rest of the appointment because they're not sure just where things are going to end up going.
You're right.
I can imagine. Well, and so who else is a part of their care team, with DNA?
Mm-hmm. So besides the nephrologist that they see, we have nurses that help the patient and really run our office. We have a nurse navigator who often helps coordinate care and pull care together. We have dietitians that we arrange consultation with as needed, and then there's other specialists in certain situations. But really, it's a whole team approach, and the nephrologist is but one part of that team.
Absolutely, with the one mission of slowly either ensuring that the progression or decrease the progression.
Yeah, slow or stabilize or halt that progression is the goal.
So do you have any other thoughts that you'd like to share if somebody's listening right now and, has just gotten a referral from a primary care physician, that what they need to be prepared for, in moving into that journey of working with nephrologists?
Yeah. The first step is come to the appointment, show up, bring a family member when you can, because two heads are better than one. And even when I go to the doctor, sometimes I walk out the door and then I suddenly realize I don't remember the conversation or all the details of the conversation I just had.
Mm-hmm.
Bringing your medicines in the bottles, the actual pills, is really important. And that seems so simple and kind of too simple, but I think that's really important.
I would not have thought of that.
Yeah.
I don't think, and I myself, as, if I look at myself as a patient, I've never had that, they start asking you about any medication that you take. And that's the point where you're either trying to scramble and remember it, or you're trying to open up your notepad,
right,
and stuff like that. So you actually recommend
the plastic bag with the actual pill bottles is the best way to go, because then you're not calling your family and saying, would you read to me the bottle that's on my dresser? And you're also not relying on a med list from another doctor's appointment from 7 months ago. And it's kind of a safety issue. Like, if we don't really know what meds you're on, I'm very nervous about prescribing anything or adjusting anything, because I don't know exactly what I'm doing.
Yeah, absolutely. And so obviously, once they've come to see you and they're starting that journey and you're having this conversation with about their new care plan specific to chronic kidney disease, what does the relationship then look like with their primary care physician?
I don't think it changes that relationship at all. They still are going to be seeing their PCP regularly, and the PCP is still the point person for their health. And I'm not trying to replace that or change that in any way. And I'm really focused on anything that touches on their kidney health and their blood pressure in particular. Other medical problems, including diabetes, really remain under the control of the PCP. So I'm not trying to overtake that.
And why do you think that's important, though, to try and not overtake that, right? Where you're not trying to just say that you only need to listen to me. Why is it important that they continue that?
Yeah. I'm not a PCP, so I'm not doing everything for that patient. I'm not keeping track of colonoscopies and PSAs, and they still need the PCP to do that. Additionally, they have usually years of track record with that PCP, and that's something I don't have. So I don't want to take away from that or replace that. And so they want to stay totally up to date with their PCP.
What do you feel like are generally some questions that you're asking patients in order to get to know them better and build that relationship with them? Because I can imagine a big piece of, some of these early appointments is establishing trust and getting to know them. We've talked about in some other episodes and conversations that, not only is every patient different and their care plan going to be very customized to them, but it's also the way that they learn and adapt to the new information can be different as well. So what types of questions do you like to ask patients?
I'm really asking about their medical history first and foremost. So trying to get at all the risk factors, which starts with diabetes and hypertension, but it may be past medications, past hospitalizations, and really get a sense of not only what medical problems started when and how they've been treated, but how did the patient adapt to all that, and were there times at which things were simply overwhelming or out of control, or has this always been a pretty under control process, and get a sense of the patient's health and sort of a trajectory of, like, is this person, doing a good job of dealing with the set of medical problems they have, or are things accelerating or snowballing, and how's this patient doing in the long view?
Being able to try and understand where they're at and meet them where they're at, because I can imagine if you feel like there is some sort of snowball or there's not being things that are not being addressed, that you want to figure out how you can work with them to alter that.
Right. Sometimes I have a meeting or two with a patient, and an appointment or two, I should say, and I get the sense this person is really clicking and they understand everything that's going on. And sometimes I say, wow, let's back up a little bit. And sometimes we're talking about medical problems and kidney health and trying to fill in gaps and make sure they really understand what's going on with their health.
Yeah. Well, and so can the health, once diagnosed with chronic kidney disease,
Mm-hmm.
can that be improved, or, can the progression be slowed?
Yes. So there's tons of patients we see in the office who have chronic kidney disease that turns out to be non-progressive, and they have a stable creatinine for years or decades. And really it turns into a relationship of checking in, reassuring them, educating them about things to look out for, but they do not have progressive CKD, and that's wonderful.
So if someone does have progressive chronic kidney disease, what's one of your goals in working with them in their appointments?
Good question. And so this is the more complicated patient. We're going to be having more appointments with them at probably a tighter interval. And goal number one is medically, I want to figure out what's the cause for that and fix everything that's possible to slow down that process. And that in it of itself may take multiple encounters. It may take lab work. It may take more imaging. In certain cases, it takes a kidney biopsy. But it's not a one-shot endeavor.
Yeah.
And then for the patients that seem to be on a trajectory towards progression, we're trying to lay out a game plan and come up with a strategy for success. And it's not a one-shot thing. It's going to be a conversation over multiple encounters, multiple appointments, and coming up with a plan that will set them up for success in a year or 2 years or more years in the future. And that's, talking about the pros and cons of transplant, dialysis, different forms of dialysis, conservative management, and this whole range of ways we take care of kidney patients.
I can imagine when you are having those appointments, do you have someone who's coming to you and they're sitting with a binder? Like, being able to keep all of this information sounds tricky.
Mm-hmm. It is. And some patients bring their own binder. Some patients who are going through CKD education, which I'm super proud of the way our practice has innovated in that area, and they have a binder that's part of that.
Oh, perfect.
But yeah, whether they have a binder or they don't have a binder, we're building a picture and a game plan for how we're going to take care of you in the long run.
Yeah, because you can have the game plan, but it's a matter of being able to build on it in each appointment, saying, okay, this is where we left off last time. This is where we need to address today. And so if they don't have progressive CKD, and I honestly didn't realize that there were some of those cases. I'm not sure if off the top of your head, what the percentage of difference is between how many do have progressive versus non-progressive.
Well, I don't know a number for you. Most patients who have CKD3 will never end up on dialysis. So let's just start right there.
Yeah.
And dialysis is what really scares a lot of people, and with good reason. But most patients who start in our office with CKD stage 3 will never see the inside of a dialysis clinic. And so there's a lot of sort of preventive care and reassurance that takes place with all those patients. And then we do have, a different kind of relationship with the patients who do have progressive CKD and are going to ultimately need renal replacement therapy, which could be dialysis or transplant. But I can say that most patients who come to see me for the first time ever are never going to see the inside of a dialysis clinic.
Well, and I asked that because I can imagine that, there's absolutely a part of the population that may only see their primary care physician once a year, and that's for an annual checkup, right? And so if all of a sudden they're being referred to a specialist, how does that relationship change? Do you expect to see them, let's say they have non-progressive CKD, do you still expect to see them once a quarter, or what does that relationship look like?
Well, initially,
I say once a quarter like it's business, but
initially I'm going to see people frequently, but for the non-progressive patients, we space out to 6 months and 12 months. And, I try to not over-doctor people. And if they're doing well and everything's under control, I'm going to see them only as much as I need to honestly keep an eye on things.
Yes, absolutely. Well, and so what are the methods of being able to improve their health or to slow that progression? What are some of the different ways that can happen?
Starting with lifestyle. You can never overemphasize lifestyle. So daily exercise, healthy diet, overall good healthy habits is so important. Within that, blood pressure. Okay. And so we spend a ton of time on blood pressure. And one of the things I say quite a lot is let's keep it simple. Blood pressure, blood pressure, blood pressure.
Mm.
And the first order of business is let's get that blood pressure within guidelines. And reasonable people can disagree about what are guidelines for different groups of patients, but I want to get all the patients to a decent blood pressure that I feel is safe.
Mm-hmm. I can imagine a big piece of that is then stress, and then it's like stress related to blood pressure. I can imagine is a big piece of the conversation.
That's a circle. Yes.
So when should a primary care physician schedule or start working, work to obtain a nephrology consultation for their patient?
Sure. So if somebody has elevated creatinine with an estimated GFR under 60, they should come see us. And if they have an albumin to creatinine ratio that's more than what we call severely increased or more than 300 milligrams per day on an estimation, they should come see us. And there's more gray areas. I mean, you can disagree about other patients, but those are things that I can confidently say would be a reason to come see the kidney doctor. But I think that anytime that the primary care doctor is unsure or uncomfortable with the state of a patient's either creatinine or blood pressure or urinalysis, they should come see us.
Something I can imagine, let's say chronic kidney disease happens to be in the family, or you're a patient and all of a sudden somebody, your friend or family gets diagnosed with CKD, and all of a sudden, they're saying to their primary care physician, have we ever looked into this? Is this something that I should get checked out as well?
Mm-hmm.
And let's say that primary care physician decides, no, I haven't seen any signs of it. Is it something that they're able to come to you directly? Like, say for some reason they have these concerns and they just kind of want to check the box that it's not an issue?
So you're saying, can a patient self-refer if they're concerned? Yeah, they can do that. That's a pretty rare thing. I would say 98% of patients who come to me are referred by the PCP or sometimes after a hospital stay.
Mm-hmm.
That's another scenario. But self-referral does happen. It's not super common. But yeah, if you have some concern about either lab work or blood pressure, then we would be happy to see.
Yeah, no, it was more just a matter of if you're sitting there with your PCP and having the conversation, and there, I think as a patient, you go in and you're kind of hoping that your PCP, for example, is doing all the right tests. You're like, I know for myself, I'm kind of like, I'm open to the tests. Like feel free to do the tests to check it off that it's not an issue. You know what I mean?
Yeah.
To make sure that we are good. So other than that, I'd love if you have any lasting thoughts about what it is like, either being a new patient or maybe you've been working with a nephrologist for years, how to continue or maybe improve their relationship with a nephrologist or improve their relationship overall with their healthcare team.
I think communication is so key with all your doctors. And in today's healthcare environment, we don't have tons of extra time. I wish we had all the time in the world, but we don't. Yep. And making those visits high yield by having your questions written down ahead of time and being ready to have that conversation. And again, the little things that sound so basic, but pill bottles with you and a family member with you, if you can swing it, is going to really help.
I'm so glad you mentioned that. I think those are, like you said, they may seem straightforward, but those are really, sounds like important pieces of advice that we need to be taking into account. So I'm incredibly grateful for your time. Thank you for sparing the few moments that I'm sure that you do have with us today.
Likewise, Bree. Thanks for having me.
Thanks for tuning in today. Learn more about Dallas Nephrology Associates at www.dneph.com. That's DNEPH.com. And if you found the information valuable, be sure to share with those also impacted by chronic kidney disease. Dallas Nephrology Associates' DNA podcast series, Let's Talk About Kidneys, is provided for general information purposes only and does not replace the need to talk with a healthcare professional about your unique situation, care, and options. Our goal is to provide you with as much information as possible so you can be as informed as possible. Reference to any specific product, service, entity, or organization does not constitute an endorsement or recommendation by DNA. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of them or any entity or organization they represent. The views and opinions expressed by DNA employees, contractors, or guests are their own and do not necessarily reflect the views of DNA or any of its representatives. Some of the resources identified in the podcast are links to other websites. These other websites may have differing privacy policies from those of DNA. Please be aware that the internet sites available through these links and the material that you may find there are not under the control of DNA. DNA shall have no responsibility for the accuracy, legality, or content of the external site or subsequent links. Contact the external site for answers to questions regarding its content. The resources included or referenced in the podcast and on the website are provided simply as a service. DNA does not recommend, approve, or endorse any of the content on the linked sites. The content provided on this website and in the podcast is not medical advice and should not be used to evaluate, diagnose, treat, or correct any medical condition. The content is solely intended to educate users regarding chronic kidney disease, end-stage renal disease, ESRD, end-stage kidney disease, ESKD, and related conditions, and ESRD, ESKD treatment options. None of the information provided on this website or referenced in the podcast is substitute for contacting a healthcare professional.